And so the first thing is TAR-210. And so TAR-210, here's a nice sort of visual about how it's deployed. It's a device that's put into the bladder, and it comes in as a tube and then curls up like a pretzel. People call this the pretzel. And, everything I've talked about before is really like a wash. So we put it in your bladder, you hold it for 2 hours, and then you pee it out. This pretzel is a device that goes in, and this one stays in for 3 months. The video is the other gemcitabine-eluting one, so the colors are a little different. But the key thing about this and why it's so cool is that this is a therapy that started as a pill. We tried to give it in a pill to people with advanced bladder cancer, and while it worked, there was a lot of toxicity because it goes throughout your whole body. So then J&J was very bright to develop this in something that goes right into the bladder. You get rid of all the toxicity and you get local therapy. And the cool thing is that many of our early bladder cancers, actually many more, in the neighborhood around 65 to 70% of early stage bladder cancer, intermediate risk, have an alteration that's directly targeted by erdafitinib. So that FGF receptor mutation, again, is much more common in early stage bladder cancer. And the response rates are very good and the therapy is very local. And so that's where a lot of us are incredibly excited about this therapy that's there for 3 months and seems to be very specific for their bladder cancer. So I just want to talk a little bit about the data and try and summarize that as well as I can. So
Can I just ask a quick question first? I just
Yep.
want to ask a quick one. How often do you take the tumor when you remove it with the TURBT through fulguration and you're taking that tumor out? How often with this non-muscle invasive do you get it tested for these genetic mutations like the FGFR that is what would react better to erdafitinib?
So evolving question. Up until now, we've not been doing it. And the reason for that, Stephanie, is that we've never had a reason to do it because I don't have anything specific for it. But now that we have a target and now that we have something to do specific for those patients, I think that's going to change. And there's two ways to do that. One of that ways is to go get a piece of the tumor and then send that off. The other is a urine test. And so, in this first in human trial, we did both. We did both urine and tissue. And it's not perfect, meaning that like just because you have it in tissue doesn't mean the urine's going to be positive. There's some that are positive in one versus the other. But if the good news is that when we look at the results, which is here, it didn't matter how you tested positive. The response rates were just as good. The other thing that may be worth questioning, and for example, in this study, patients didn't have their tumor resected. So they had a tumor and the device went in. So this is an ablative therapy here. And so that's also very exciting because you think about trying to decrease the number of procedures that people had, because that's one of the huge burdens for intermediate risk is a lot of surgery, a lot of endoscopy, a lot of procedures, whereas this device, when it goes in there, it can just ablate the tumor. That's at least what this data suggests. So these are swimmer's plots, and you look at the time points at the bottom. And so again, you have a 90% complete response rate at 12 weeks of these tumors that were ablated. So all of these patients started out with tumor that just went away. And so, and again, overall 100% of patients achieved a clinical response. So that's really amazing. And then when you look at the duration of response, that's hitting 89% at 9 months. So I think this is a really exciting change to this field. We know a major target, again, found in anywhere from 60 to 70% of patients, and the duration of response seems to be very, very good.
Great. This is a device. The pretzel itself is a delivery mechanism, right? So they can also use it for other things like chemotherapy and other medicine that can go into that device.
Yeah. So again, this is sort of J&J's pipeline. So the question would be how it's engineered. I mean, they're incredibly smart people and great to talk to about, what you could do with this. But yeah, the pretzel is the shape. And when if you ever get to see one up close, there's little small pellets of medication in there. And you're right, your mind starts thinking about what else you could potentially put in there, you know, as far as medication delivery. And it makes sense that you have something that's there all the time as opposed to hold it for 2 hours and hope it works. This just sits there. Now, I think the downside is, and I don't know that I have a tolerability slide. Um, I don't. But you know, there are people who have a little more bladder spasm with this. So I think, you know, again, it's not going to be perfect for everybody. And if you have bladder spasms with it, we're learning how to try to manage that, but some people are going to need breaks, and we may have to figure out how to do that. I wanted to just show this. This is like looking at blood versus urine concentrations. And so if you look at the blood concentrations, the red and blue and black lines are the two different doses. If you compare those to the urine concentrations, you know, again, we're looking at 40 on the blood, and in the urine, you're getting in the 1 to 2,000 levels. So the dose is very, very high in the urine, meaning that the drug is working great in the bladder. So it's, you know, it's 50-fold lower in the blood than it is in the urine. And that's why you're getting the response without the toxicity.
And that makes sense when you have that non-muscle invasive, it
Yep.
really is on that inner lining. So getting it into your bloodstream is not as important
Right.
because the odds of there being a cancer cell somewhere else are very slim. So yeah, that makes sense.
And so this is the trial that is ongoing with this now, and this is, you know, a really important trial. So again, this is FGF receptor positive patients. So we've tested their tumor, and it's comparing chemotherapy, which we've talked about, that's a standard of care, versus TAR-210. And it's 270 patients in each arm. This is, you know, big trial, enrolling now. So we're excited to see, like, is it better, right? And the question is going to be, how long can people go without tumors, and comparing these two treatment options. And this is how this new standard of care becomes available, is that we compare these two. And so this is ongoing. This is called Moonrise 1. There's more Moonrises coming, but I think this is a really exciting trial in the space, and we're really going to be excited to see what it shows. UGN 102. So this is another therapy. And so the really neat thing about this for our patients is that this is an ablative treatment. So the hope is with this that, again, we can spare patients from TURBT. And so the way that this sort of was tested, again, this is the Atlas trial. So I'm just showing you this so you have a sense of comparison. So this was UGN 102 compared to TURBT. And then if patients had tumor, they could then undergo a TURBT in the UGN 102 arm. And so this is a chemotherapy. So we talked about mitomycin, and in general, the way that's administered in our clinic is you come in, we put a catheter in, the therapy gets put in, you hold it for, you know, 60 to 120 minutes, and then you urinate it out. This is, you know, more forms a solid gel in the bladder, and it's urinated out much longer. So it's in the bladder for a much longer duration of time. And so because of that, this is the, if you know about gel mito, that's what's used in the kidney. This is UGN 102 is a very similar version of that, but used in the bladder. And so this is, again, some of those Kaplan-Meier curves comparing UGN 102 versus TURBT rate. And even though the response is about the same, when you look over time, you know, people with UGN 102 have less events, and they do much better over time. So this was the Atlas trial that was published, and then this led to a single arm trial. This is Envision. And again, this is UGN 102 single arm trial given weekly for 6 weeks. And then how did the people do at 3 months? And so looking at response rate, 80% complete response rate of 100, almost 200 patients. So that's really good. So 82.3% with remain disease-free of those 90%. So again, the hope here is that, you know, is this going to work for everybody? Hard to know, but we have another therapy for people that, you know, before are just tired of getting procedures, tired of getting fulgurations, and you're looking at durability of response of 82.3% when you get those 6 doses of UGN-102. So I think that is a real option for folks. I mean, again, it'll be really nice to have more than one option, and you could see why this would be very good for patients, because again, if you look across the board, the consistent response rate at 3 months is somewhere between 65 and 80% of tumors that just go away without the need for a TURBT. Well,
Yeah,
are you
it's
hearing
great
that?
because,
Yeah.
yeah, I think, again, that's also sort of what you get with BCG in the high risk. It's about 65% roughly, right? And so the idea to be able to have that medicine stay against that tumor for a longer period of time makes more sense, to be able to have that reaction to get rid of the cancer.
Without needing a TURBT. And again, some of it
Mhm.
is like preference, but as you know, there's a lot of folks that we see that are just not well. And so trying to
Right.
get the surgery and stop blood thinners and even there are, as you know, there are no small surgeries. So if there's a reason to try to avoid that, I think there's also a concern of, how could this be portable? Can this be done well without as a procedure first? So I think there's a lot of interest in this going forward. The last thing I'm going to talk about is CG007 or cretostimogene. And again, this is a pretty really interesting sort of future thinking kind of therapy. And again, this is a therapy that's put into a viral vector that finds its way into bladder cancer cells. It causes the cells to replicate and die, and then that causes more immune cells to come. So there is some specificity to that, because it doesn't seem to replicate in normal cells and only replicates in bladder cancer cells. So there is some precision involved in that. And so this is their phase 3 trial. This is what they call Pivot 006. It does allow some high-grade tumors, but again, it's comparing TURBT to intravesical cretostimogene, 6 weekly doses followed by 3 doses at 3, 6, and 12 months. So I think, again, this is a really new and innovative therapy. It seems to have really good outcomes in BCG unresponsive folks, and then we're moving this early into intermediate risk. And so I just think about, if you look at these 3 alone, there's so much promise here to be able to offer patients when they say, I'm tired of having this cancer that keeps coming back. What do you have? And they're all different, right? So you've got a viral therapy, you've got a ablative gel, and then you've got a device. And so, you know, it's just so many more options that we have in the future, potentially, if all of these are effective. And again, these are the sites for Pivot 006.